Hi, my dear students. I'm Dr. Jeetu. Today we'll be dealing with mucogingival surgery. I have referred currents as 13th edition for this. It is a pretty big chapter, but there are a lot of figures and it is easy to understand. Going into the presentation. These all are the topics that will be covered under mucogingival surgeries. One is the techniques to increase the width of attached gingiva and for root coverage. Then we have crown lengthening procedures. We have vestibular extension procedures, procedures to correct aberrant frenum, papilla reconstruction, ridge augmentation and depigmentation. All these procedures are mucogingival surgeries. So the first procedure that we mentioned was gingival augmentation. Gingival augmentation can be apical to area of gingival recession or it can be coronal to the area of recession. When we augment apical to the area of recession, the donor graft tissue is placed apical to receded gingival margin. Here, there is no attempt made to cover the denuded root surface. The root surface is exposed, but our intention is not to cover this. It is to increase the width of the attached gingiva or the keratinized tissue. The second one is coronal to recession. If we are placing a tissue coronal to recession, it is for covering the root. Here, the donor graft tissue is placed covering the denuded root surface. So when we talk about root coverage procedures, the most important classification that we should discuss is Miller's classification. There are a number of classifications and the recentmost one came in 2018. It is Nagappa and Mukta's classification. But anyway, the most common and the most popular one is Miller's classification. There are 4 classes, class 1, 2, 3, 4. Class 1 is marginal tissue recession that has not reached mucogingival junction. 2 is marginal tissue recession reaching mucogingival junction, but there is no soft tissue loss, no bone loss. 3 is marginal tissue recession reaching mucogingival junction. There is soft tissue loss and minor bone loss. There is malpositioning of tooth also. In 4, it is marginal tissue recession reaching mucogingival junction with severe soft tissue loss and bone loss and severe malpositioning of the teeth. So that is about Miller's classification. So when we attempt to cover this denuded root surface, we can use autografts or allografts. Autografts means the graft is taken from the same person and it can be free or pedicle. Free means the graft tissue is freed from its original site. For example, you want to cover a lower anterior teeth labial tissue recession and you are taking a connective tissue graft from the palatal area. So this is a free graft. Free autograft, whereas pedicle graft, it is pedicled at its base in its original site. It is not completely freed from its original site. So a lateral pedicle graft where the graft tissue is just laterally repositioned without cutting it from its base. This is a pedicle graft. So this is about autograft. Then we can also place allografts to cover root recession. This pedicle grafts can be again of 2 types. It can be rotational flap or it can be a advanced flap. Rotational flap means it is rotated or displaced laterally. So the major 3 procedures coming under this are laterally positioned flap, transpositional flap and double papilla flap where the flap is rotated or displaced laterally. Then we have the advanced flap where there is no rotation or lateral migration. The flap is advanced in a coronal direction. For example, coronally positioned flap, subepithelial connective tissue graft, guided tissue regeneration, pouch and tunnel technique. All these involve advancement of the flap coronally. There are numerous root coverage procedures. We'll be discussing the most important ones. The first one is free gingival autograft. It was introduced by Yon in 1963, but the term was introduced by neighbors in 1966. As it is clear from the figure, first we prepare the recipient site. The recipient site blood vessels should be exposed in order to have an anastomosis with the blood vessels of the donor tissue. Then I obtain the donor tissue from the palatal area of the patient. Then the graft obtained is immobilized at the recipient site and it is sutured. This is the procedure in short. So free gingival graft was introduced by Yon in 1963 and the term was introduced by neighbors in 1966. Then there are 3 modifications for this free gingival graft. The one is called accordion technique, which is introduced by Ratajczak. Here alternate incisions are given on the opposite sides of the graft. As you can see from the figure, we have a square or a rectangular piece of graft tissue. Incisions are placed on alternate sides of the graft tissue so that it becomes more stretchable. So you can cover more area by using this technique. The second modification is strip technique. It was given by Han. Here 2 or 3 strips about 3 to 5 millimeter wide is used. We can see small thin strips. A number of these strips are used to cover the recipient site. The third one is combination epithelial connective tissue graft. Here a very deep graft is taken from the palate, almost 3 to 4 millimeters thick graft is taken from the palate. Then you can split this piece of graft cross-sectionally into a pure connective tissue strip and a strip containing epithelium and connective tissue, and both these can be used for root coverage procedure. So that is about free gingival autograft. Now going into the healing phase. When we place free gingival autograft, the healing goes through 3 phases. First is the initial phase, which lasts 0 to 3 days. This is the phase of plasmatic circulation. At this time, the recipient site has the donor tissue, and this donor tissue is maintained using plasmatic circulation. The second phase is revascularization phase, that is from 2 to 11 days. Here anastomosis will be established between the blood vessels. Using plasmatic circulation, it was surviving. From 2 to 11 days during the revascularization phase, there is an anastomosis between the blood vessels. The third phase, or the tissue maturation phase, is from 11 to 42 days. During this time, the number of the blood vessels gradually becomes reduced and the tissue almost matures. So there are 3 phases: initial, revascularization and tissue maturation. Coming into allogenous graft materials, these are some new additions in the current SAS 13th edition. The first allogenous material is ADM, or acellular dermal matrix. What is happening here? Here a donated human tissue is chemically processed to remove all the epidermal and the dermal cells. So it is clear from the term, it is acellular, there are no cells, and we are preserving the bioactive dermal matrix. It is approved by FDA as an autograft substitute, and there are 2 techniques to place ADM for root coverage procedures. It is alternate papilla tunnel and papilla retention pouch. This can be given as MCQ. What is alternate papilla tunnel? It is a root coverage procedure. It is a vestibular extension procedure. It is a depigmentation technique. So they can confuse you. We have to remember that it is a root coverage technique using acellular dermal matrix, alternate papilla tunnel and papilla retention pouch. Okay. So after ADM, the next allogenous material is live cell-based therapies. Using the first one was not having any cells. Then we have live cell-based therapies, which include 2 things. The first one is human fibroblast derived dermal substitute. Here what we are doing, we cultivate human diploid fibroblast on a polymer scaffold. So fibroblasts are cultivated on a sheet. Now these living fibroblast, it is usually obtained from the newborn foreskin. This will release a number of growth factors, and hence we expect the recipient site tissue to grow and cover the recession. So that was fibroblast derived dermal substitute. It was a single layered polymer scaffold which was containing human diploid fibroblast. Next one is living bilayered skin substitute. It is bilayered here. Okay, here they can generate attached gingiva around a tooth that do not require any root coverage. Usually it is used for gingival augmentation and not for root coverage. This is the first human cell derived substitute approved by FDA. Even though we had a human fibroblast derived dermal substitute, the living bilayered skin substitute was the first FDA approved one. Here, as we already said, there are 2 layers. The dermal layer is produced by the combination of fibroblast with collagen, serum and some culture media, and over this a suspension of keratinocytes is added. So it is simulating the dermal layer and the epidermal layer. So we have a dermal layer, and over this we have a keratinocyte suspension layer. This is living bilayered skin substitute. Now shall we discuss the important root coverage techniques. First one is free connective tissue autograft. Just like free gingival graft or FGG, this is also freed from its original site, but the thing is it is connective tissue autograft, meaning to say it is a pure connective tissue piece. It is not having a epithelial layer over it. It was first proposed by Edel in 1974. It was introduced in oral and maxillofacial surgery. Then we started using this in Perio also. It was explained by Levin in 1991 in detail. So what is happening here? It is a pure connective tissue graft. Therefore, it has to be covered with a tin foil or something because we don't want to expose that to the atmosphere. The second one is subepithelial connective tissue graft. It was given by Langer and Langer. So Langer and Langer were thinking, why place the connective tissue graft and cover it with a thin tin foil. He suggested placing the connective tissue graft and over that pulling the epithelium of the recipient site coronally and covering the graft. So this is known as subepithelial connective tissue graft. The connective tissue is placed under the epithelium. Clear? It is given in the diagram also. Have a look on that. Next is lateral pedicle graft. It was given by Group and Warren. As it is clear from the diagram, there was a recession on the tooth marked R. It is the recipient. You can see the gingival recession over that area, and the tooth marked D is the donor. So from that site we obtain a graft and it is rotated to cover the recipient site. Now you may get a doubt, after doing this the donor tissue is going to suffer from this thing, recession. No, the tissue over the donor site is healthy and it is going to regenerate naturally. The next one is coronally displaced flap. We already discussed in Langer and Langer technique, when we have to place a subepithelial connective tissue graft, the recipient site should be displaced coronally. So similar to that, pure coronally displaced flap was given by Norberg in 1926. Then a modification of this was semilunar coronally positioned flap given by Tarnow in 1986. It is usually used for maxillary tooth with minimal recession. As you can see, semilunar incisions are given above the gingival margin of receded tooth. Then we are pushing this tissue coronally, pushing this tissue coronally, and it is left without any sutures also. It will be retained in that position with our finger pressure as well as with the help of gravity. Next technique is called pouch and tunnel technique. It was given by Robert Azzi et al. As it is clear from the figure, we create a pouch under the papillas. You can see the instrument is, the pouch is created and the instrument is passing through a tunnel that we created. Then through this tunnel, you can see a connective tissue graft is passed and we displace the tissue coronally and it is sutured. So by now I think you will be clear with the indication. For multiple recession, usually we use the pouch and tunnel technique, but it can also be used for single tooth recession. We know in the healing phase of the free gingival graft we had 3 phases. One was the initial phase, second was the revascularization phase, and third was the tissue maturation phase. In the healing of the pedicle grafts we have 4 stages. One is the adaptation stage, which lasts from 0 to 4 days. That means the donor tissue is adapting over the recipient site. Second one is the proliferation stage from 4 to 21 days. Here, what is proliferating? Fibroblasts are proliferating. Fibroblastic proliferation happens, and towards the end of this phase, they start laying down collagen. Attachment stage is from 27 to 28 days. Here, thin collagen fibers become inserted in a new layer of cementum which is formed at the root surface. So we already said collagen fibers start forming in the end of the proliferation stage. These become inserted into the new cementum formed. So that is now why it is known as the attachment stage. Fibroblast is attaching to the cemental surface. And finally we have the maturation stage. Here continuous formation of collagen fibers happen and healing is continuously happening. After 2 to 3 months, bundles of collagen fibers will insert into the cementum and the newly formed tissue will be matured. To management of frenum, we know frenectomy and frenotomy refers to surgical procedures that differ only in their degree. So basically both are same procedures. Frenectomy means, as we all know, ectomy means cutting or excision. So it is the complete removal of the frenum, including its attachment to the underlying bone. But frenotomy doesn't involve complete removal of the frenum. It is just a relocation of the frenum, usually to a more apical position. So just if you are cutting the frenal attachment and relocating it apically, it becomes a frenotomy. And frenectomy means cutting this frenum fully and its attachment to the underlying bone is also removed. Clear with that? The next procedure that we should know is crown lengthening. Crown lengthening is a very important mucogingival surgery in terms of perio. So first we will see what passive eruption is. There are 4 stages of passive eruption. As we all know, when the tooth moves out of the bone and of the gingiva, this movement of the tooth itself is known as active eruption. And after the active eruption is completed, the gingiva moves over the teeth in an apical direction. This is known as passive eruption. So in that stage 1 is dentogingival junction, or the junctional epithelium is on the enamel. You can see from the figure. In stage 2, dentogingival junction is located on enamel as well as on cementum. You can see it is partly on enamel and partly on cementum. In stage 3, junctional epithelium is entirely on cementum, extending coronally to the CEJ. So it is not on enamel, it is fully on cementum, extending up to CEJ. In stage 4, it is entirely on cementum and the root surface is exposed. So gingiva has receded too much apically so that some root surface is exposed and there is gingival recession. These are the stages of passive eruption. And we know this is the normal passive eruption. When there is altered passive eruption, this will often warrant the use of crown lengthening. So there are 4 types of altered passive eruption. This classification was given by Coslet. There is type 1A, type 1B, 2A and 2B. Type 1 is, in simple terms, wide band of keratinized tissue. So type 1A is wide band of keratinized tissue plus the alveolar crest to CEJ distance is normal, 1.5 millimeter distance. Look at the figure also. Type 1A, there is a wide band of keratinized tissue and the distance between alveolar crest and CEJ is normal. Type 1B is, we already said 1 means wide keratinized tissue. So wide keratinized tissue is there. And what is B? B is alveolar crest and CEJ has no distance. It is at the same level. Alveolar bone crest lies at the level of the CEJ. And in simple terms, type 2A is a normal band of keratinized tissue. There is no wide keratinized tissue. It is just a normal band of keratinized tissue. And A, as we all know, is normal distance between alveolar crest and CEJ, and B is alveolar crest to CEJ distance is 0. Treatment crown lengthening can be done using various techniques and this is dependent upon this classification. In case of type 1, there is a wide band of keratinized tissue, therefore we can do gingivectomy. In 1A, since the distance between alveolar crest and CEJ is normal, we don't need a osseous surgery. So in type 1A, we can expose the crown or lengthen the crown purely by using gingivectomy. In 1B, we have to use gingivectomy as well as some osseous surgery because the alveolar crest is at the level of CEJ and we want to move the alveolar crest apically by reducing it. Therefore, 1B warrants gingivectomy plus osseous surgery. In type 2, whether it is A or B, we can't do gingivectomy because there is no excess of keratinized tissue, so we are doing an apically positioned flap. Since there is adequate distance between alveolar crest and CEJ, we don't need a osseous surgery in type A, but we need osseous surgery in type B. So once again, type 1A can be treated with gingivectomy, 1B gingivectomy plus osseous surgery, 2A apically positioned flap, 2B apically positioned flap plus osseous surgery. So the one thing that we should take care when we are doing gingivectomy is if after excision of the soft tissue there is 3 mm of keratinized marginal tissue remaining, then there is no need for osseous surgery because to maintain health we need at least 3 mm of keratinized marginal tissue. So soft tissue excision alone will be the treatment of choice. But after excision, if there is less than 3 mm of keratinized tissue remaining, then we have to do an apically positioned flap also. So we have to keep in mind something. We need at least 3 mm of keratinized tissue to maintain health. So if excision of the soft tissue, after excision also, if there is at least 3 mm of keratinized tissue, then we can just do soft tissue excision. That is our treatment of choice and we don't need any osseous surgery also. But if less than 3 mm of keratinized marginal tissue will be remaining after the excision, then don't go for excision. You have to do an apically positioned flap in that case. So leaving behind 3 mm of keratinized tissue is the key. Moving on to the next procedure that is papilla reconstruction. You would have seen black triangles. Now it is very unaesthetic. So the treatment of choice in that case is reconstructing the lost papilla. The first technique is semilunar coronally repositioned papilla with a free gingival graft. So it is very similar to our semilunar technique for root coverage. We are giving a semilunar incision apical to the gingival margin and we were pushing that coronally to cover the recession. That was for root coverage procedure. Similarly, if you are giving this semilunar incision in the papillary area, and along with that, if you are using a free gingival graft, that can do the papillary reconstruction. It was given by Han and Takai in 1996. The next technique is envelope type flap. It was given by Azzi et al. Azzi et al. Had already given pouch and tunnel technique for root coverage. Here, he applied the principle of pouch and tunnel to maximize the blood supply to the grafted tissue. So, we are creating a pouch and we are placing the tissue inside the tunnel created so that the blood supply is intact. Third technique is pedicle graft plus a soft tissue graft from the palatal area. It is given by Beagle in 1992. It is also known as Beagle's technique. Here what we are doing, here we cut a piece of tissue from the palatal side of the tooth and this tissue is folded upon itself to fill the papillary area. Along with this we can use a soft tissue graft from the palate also. Another technique is injecting of autologous fibroblast into the interdental papilla. This is a relatively atraumatic procedure and it can augment the deficient interdental papilla. Next is vestibuloplasty. Like all other mucogingival procedures, this also has a lot of techniques, but the major three techniques are Kazanjian technique, Clark technique and Edlen-Mecher technique. So even though we are not going to discuss how these techniques are done in detail, these names you should keep in mind. These techniques are used for vestibuloplasty. Kazanjian's technique, Clark's technique, Edlen-Mecher, all are vestibuloplasty procedures. Next mucogingival procedure is ridge augmentation. So ridge augmentation means it can be hard augmentation and soft tissue augmentation. The hard tissue or the alveolar ridge augmentation can be done using two techniques, distraction osteogenesis and ridge splitting. We know what is distraction osteogenesis. We cut a bone and we apply tension to the bone so that there will be bone formation and bone fill. And we can also do ridge splitting. We can split off the ridge and increase the width of the ridge. Then pure soft tissue augmentation procedures include, again just for root coverage procedure how we were classifying, pedicle graft procedures and free graft procedures. Pedicle graft procedure is like our roll technique. We are cutting a piece of tissue and rolling that piece of tissue on itself. So this will increase the thickness of the ridge. Then free procedures include pouch graft procedure, interpositional graft procedure and onlay graft procedure. So all these three, the donor tissue is completely separated from its site and it is stitched upon or sutured upon the recipient site. For pouch graft, interpositional graft and onlay graft. Three are free graft procedures for soft tissue ridge augmentation. Coming to the last procedure, depigmentation. Depigmentation is the removal of the excess melanin pigment from the gingiva. So we can use two strategies. One is methods used to remove pigmentation. So if there is excessive pigmentation, you can remove that pigmentation. The second strategy is masking that pigmentation. So the methods used to remove pigmentation includes surgical methods and chemical methods. Surgical methods, as we all know, there are different methods to perform a surgery. It can be a scalpel surgery, it can be using burr abrasion, electrosurgery, cryosurgery, lasers and even radiosurgery we use to do the depigmentation surgery. The chemical method used to remove pigmentation includes use of chemicals like phenols, salicylic acids, glycolic acids, alcohols, all these. So these techniques are not used frequently nowadays because this use of these chemicals are very damaging to your gingiva. As we all know, they use acids and alcohols and we can't control the depth of penetration of these once we apply this to the gingiva. So it is not recommended. So as I said, there are methods used to remove pigmentation and there are also methods to mask pigmentation. For example, ADM, we already discussed, acellular dermal matrix. It was used for root coverage, right? Or it was used for gingival augmentation. Similarly, you can place acellular dermal matrix over the pigmented area so that we can mask the pigmentation. Similar to that, we can use FGG or a free gingival graft from the palatal area to mask the pigmentation. Recently, we have found these things to be useful for depigmentation of gingiva. One is ascorbic acid or vitamin C. This inhibits the tyrosinase activity. We know for the production of melanin also we require the tyrosinase enzyme. So, since vitamin C or ascorbic acid inhibits this, it can reduce the melanin pigmentation. One thing is kojic acid. Kojic acid is actually a product of a fungus. It can also be produced by fermenting rice. It is a byproduct of fermentation of rice. It is used by the Japanese people usually. So kojic acid is also very effective in reducing pigmentation because it can, the same mechanism of action, it can also inhibit tyrosinase activity. And the third recent advance is placental extract. Application of placental extracts is also found to reduce gingival pigmentation. So that's all. I hope now you have a good idea about all the mucogingival procedures, and we have almost covered the important topics that could be asked for multiple choice. Just go through your current 13th edition. There are figures and there are some new additions. Please go through and let me know if you have any doubts. Thank you.